the selection of viruses that is here. First of all, I want to tell you, you can ask me about any virus you want. I'm not saying that I know about all of them, but even if the virus is not here, we can still have a conversation. Of course, I'm not going to include it in the exam. I love to talk about them. So if you have any questions, we can talk about it. Okay. So the next one that I want to chat about, and I have, since I'm kind of in my spare time, I'm writing like a virology course. If you want, we can just throw in a couple more. I can tell you about polio, I can tell you about rhino, hepatitis A, hepatitis B, hepatitis C. I just picked some sort of representative virus for different groups. So these ones are going to be double-strand DNA viruses. Okay, herpes viruses, enveloped. So these are probably, it's not biggest human virus, but they still very large. In fact, cytomegalovirus has the biggest genome size among all human viruses. 220,000 base pairs. To give you a perspective on the number of genes in the herpes viruses, we are talking about 180 ballpark open reading frames. And I deliberately say open reading frames because we still do not know the functions of all the genes in herpes viruses. So structurally, all herpes viruses share the same features. They have double-stranded DNA packaged in the icosahedral capsid. Icosahedral capsid is surrounded by the layer of the tegument proteins. And then outside of the tegument layer is the lipid envelope, the phospholipid bilayer, incorporate with viral glycoproteins incorporated in this bilayer. So you can see that structurally they are pretty complex. The function of the tegument proteins that you just saw, but we never mentioned it before, is, think about this, when virus enters the cell, so it attaches to the receptors, these viruses are endocytosed, okay? Endosome is acidified, envelope disassembles, and capsid and tegument proteins are released in the cell. Tegument proteins take over a number of cellular signaling mechanisms. For instance, they inhibit immune response, interferon response in the cell. Does that make sense? It's like, first, they're ready to go, like ready to go meal. You don't have to cook anything yet, okay? Does that make sense? It's like salsa with chips. You know, you put it on the table while everything is cooking in the oven. They can be, and they are, taxonomically divided into the three, so Herpes viridae family and three genera. Alpha, three subfamilies. Alpha Herpes viridae, Beta Herpes viridae, Gamma Herpes viridae. So I did a little bit of a coding here. Information about alpha herpes viruses is in bold. Beta herpes viruses in italic. And gamma is underlined. Just, you can orient yourself. However, all herpes viruses share same features. They're large. They all have the same structure, similar structure. Okay. They all become latent. All of them, no exceptions. And they become latent by forming. Remember, I think we talked about it. We didn't. Crap, I forgot. Probably we didn't. They form so-called episomal DNA. Did we talk about it? No? Okay. So what does that mean for the DNA to be episomal? I'm going to picture at the bottom of the slide. So this is the cell, okay? Black circle is the cell nucleus. Can you see that? And the two black lines is the cellular DNA. Are we clear so far? When virus, which I'm going to picture red, enters the cell, and this two lines in the center of that little circle is the viral DNA. Eventually, I'm going to skip through many stages of infection. Eventually, virus DNA ends up in the nucleus. Okay? And the nucleus, when virus becomes latent, viral DNA becomes circular and exists separately from the cellular DNA but in the nucleus. Does that make sense? What does the word epi mean? Above. So episomal means above the chromosome. It is not a part of the cellular chromosome, but it shares the space. Does that make sense? This is called episomal form. And sorry, that DNA sits there without any, practically no transcription, no translation. And upon what keeps herpes viruses from replicating? Immune system. I compare herpes viruses and immune system relationships with a game of whack-a-mole. Herpes virus starts to replicate, your immune system shuts it down. It starts to replicate, just makes an attempt to replicate, it shuts it down. What happens if your immune system is down itself? They reactivate. Yep, they reactivate. Think about this. The cold sore. You have cold sores when you are sick or stressed or just finished to be sick, right? So herpes viruses reactivate when your immune system is down. They all can be transmitted by bodily fluids, with one tiny little exception. We'll discuss it. Okay, by bodily fluids, I mean predominantly saliva and urine. Which cohort of people frequently exchange saliva and urine? Maybe indirectly. Not really hygienic. Toddlers, yes, you're absolutely right. Kids, not only toddlers, they don't get any more hygienic when they 12, maybe a little. Okay? So infection with these viruses usually occur early in life. Some people are more lucky than others. Some people stay free of certain viruses for a very long time. It's pretty much if a mother is a latent carrier of herpes, if she at some point has a cold sore, which means there's a replication, and sometimes it's sufficient to just kiss a child, and there's going to be transmission. It's essentially not vertical. It's just from one person to another via bodily fluids. All these viruses have high prevalence in the population. At some age, you can find in certain regions at some age up to 100% of people can be positive for herpes or Epstein-Barr or Kaposi sarcoma virus. They're not dying, they're just positive. They have latent infection. That makes sense. So latency, high prevalence, reactivation when immune system is in decline. That makes sense. Let's talk about each individual. Who had chickenpox? No, actual chickenpox? It's pretty cool. No, I'm seriously, it's pretty cool. We have vaccine now. I never had chickenpox, honestly. My mom was always scared that I will get one, so when I don't know how it is treated here. Back home, we have a medicine. It's more like disinfecting treatment for wounds. It's called the brilliant green. It's pretty much a dye, a chemical dye, and it has broad antimicrobial activity. And when I was a kid, like, you get a cut or you scrape your hand, you have a tincture of brilliant green and you put it on the wound, and it supposedly provides some antiseptic treatment to the wound. It burns like hell, but a few seconds. Okay, so when people got chickenpox, they, on those little bumps, the little pox, they put the brilliant green, so the person looked like I don't know what. Like the whole face was in those little green dots. Maybe they did it to kind of label them. You see, those are pariah of society. You don't approach them. They're infectious. So when my mom saw one, she said, "Oh, like, go on the other side of the street. You're gonna get one." So transmission is also respiratory, in addition to bodily fluids. In fact, before the vaccine was available, and unfortunately sometime after that, some parents held so-called chickenpox parties. Never heard of them? So they had one child with chickenpox and a bunch of kids without, and they shared like lollipops and, cough on each other and whatnot in attempt to immunize all of them. So they like have disease altogether. It sounds really stupid for me. Especially now we have very effective vaccine. Those of you, never had it, but those who had, was it awful? Like absolutely horrible near-death experience? Yeah, it wasn't, as far as I was told. What's the problem with chickenpox? Why we vaccinate? Yes, there you go. Shingles. So what happens to the acute infection with chickenpox? Varicella zoster. The virus becomes latent in the neurons of thoracic spinal nerves. And when you become older and your immune system becomes older and less functional, it reactivates. You can even see the traces of those bumps on the back of people with shingles. They follow the pattern of the spinal nerves. You can, of course, not necessarily only on the thoracic region of the back. It can go up, get on the neck and upper back. And as far as I know, it's painful. It's painful, and it's itchy, and the lousy part about it, bumps go away, skin is clean, but it keeps hurting for weeks. So now we have the vaccine, the shingles vaccine, that elderly, it's recommended for people over 55 can use for vaccination. Pretty much kind of boosts your immune system. So it keeps varicella zoster under the pressure. Does that make sense? Now, can it be life-threatening infection in immunocompromised people? Yes, absolutely. The virus, since it's in neurons, it can overwhelmingly proliferate, migrate to the neurons of CNS and cause encephalitis. There are recorded cases. Same goes for herpes, that infects neurons and mostly in the face. If it's type 1 herpes. Herpes type 2, same tropism neurons but in the genitalia. Other than causing rather unpleasant cold sores, Now this, I can vouch, it's quite inconvenient. They itchy, and they can bleed, and they aesthetically unpleasant, okay? Other than that, for the healthy human, doesn't cause any more troubles. However, in immunocompromised, herpes virus encephalitis is very common, and it has very poor prognosis. It's fairly deadly. One of the big problems with herpes, as with some other herpes virus, with other herpes viruses, is the vertical transmission. If you would look up congenital or neonatal herpes, it is very disturbing, very graphic picture. Kids who acquire herpes from their mothers, and of course it's mostly genital herpes. Okay, it can be transplacental, but mostly genital herpes they acquire passing the birth canal. They have good chances to die, unfortunately, and if they survive, they often have multiple systemic issues associated with the herpes virus infection. It can be mental retardation, deafness, eye infections, blindness, or loss of vision, and so on. Does that make sense? Cytomegalovirus. It's kind of a cute virus. I worked on it for 5 years. It's cute not because I worked on it. Just cute because the initial infection is mostly asymptomatic. Can manifest a little like mono, but most people get it asymptomatically. I was lucky. I'm CMV free. I was tested. Not that I was particularly interested, but my colleagues got me tested. They needed my blood, and it had to be CMV free. So I know at least at that time I didn't have. This virus infects monocytes and stays latent in the monocytes. It doesn't do anything. Healthy people just doesn't. It is implicated in progression of cardiovascular disease. In experimental studies, it was shown to be associated with hypertension, atherosclerosis, and other troubles like that. But when a person with CMV becomes immunocompromised, that can be a problem, like in patients with AIDS. Also, CMV is the major infectious cause of kidney transplant rejection. When you have a person who receives the kidney transplant, what does this person receive after the transplantation? What kind of therapy? Immunosuppressive therapy. So immune system of that person is essentially down. If a patient receives a kidney from cytomegalovirus positive donor, kidneys inevitably carry monocytes that have CMV. And when they get into the immunosuppressed recipient, virus starts to reproduce, okay? It infects the vascular tissue, it infects the endothelial cells of the renal artery, and it doesn't kill anything, it just induces inflammation. Inflammation leads to repair leads to the intimal thickening, which means artery will start to become more and more narrow. Blood flow to the transplant will cease. Transplant will die of hypoxia. Usually 1-2 years. And the person needs new transplant. So now it's a huge focus to do the transplantation from CMV negative donor. Make sense? We have no vaccine for CMV. It can also cause congenital disease. And it's also very bad. There are multiple stories of the parents whose child acquired CMV during birth or got it transplacentally. Deafness, mental retardation, physical, not retardation, but like paralysis, lack of the limb control, impaired limb control. It's all pretty common. Usually people who survived through the congenital CMV, they have different types of deficiencies. Thank you so much. Now, Epstein-Barr. Here we go. Mono, the causative agent of infectious mononucleosis. Infectious mononucleosis is pretty much fatigue, fever, accumulation of white blood cells, and enlargement of the lymph nodes. Virus replicates in epithelial cells and then infects B cells. It becomes latent in B cells. Okay. And in healthy, well-fed, not malnourished people, Epstein-Barr remains Epstein-Barr for a long time, not causing anything. It was actually discovered by two people, Epstein and Barr, in Africa. In Africa, the common complication of Epstein-Barr infection are two cancers, Burkitt's lymphoma and nasopharyngeal carcinoma. Burkitt's lymphoma is essentially B-cell lymphoma. Nasopharyngeal carcinoma is the cancerous, the malignant tumor of nasopharynx, which is very disfiguring. It is caused. We know that Epstein-Barr virus can cause it. It's not just association. And now Epstein-Barr virus is being implicated in more and more of head and neck cancers. So it's not that benign. I have no vaccine to it. Another gamma herpes virus that is worth of note is Kaposi sarcoma virus. It was named after the Hungarian doctor, Kaposi. This is a hallmark disease of AIDS patients. I do not have a picture of Kaposi sarcoma. It's purplish, huge purplish spots in the skin, tumors. And this virus, in immunocompromised patients, mostly AIDS patients, reactivates and causes cancer. And it's rapidly progressing, deadly cancer. Right? When I say hallmark disease, if you would look at there's a patient, comes in the hospital, looks wasted, with those purple spots, respiratory insufficiencies, and diarrhea. You have to suspect AIDS right away. Kaposi sarcoma, fungal infection of the lungs, different sorts. It can be PCP, it can be Cryptococcus, there are plenty of them. Diarrhea, probably Cryptosporidium. So you kind of, when I say hallmark, those are infections that are commonly, secondary infections commonly associated with AIDS. Does that make sense? Sorry, Sonora. So, there's no vaccine. We don't have a vaccine against herpes viruses except for chickenpox. But we do have a treatment. The drug is called acyclovir. This is it. It's the analog of nucleoside. So you see, it misses the sugar residue, but it has the nitrogenous base. It essentially stops the synthesis of the virus DNA. Okay? And it is kind of broad spectrum and treats any herpes virus disease. The problem is that it is quite toxic. And speaking of toxicity, why? Why do you think it's going to be toxic if it inhibits synthesis of the virus DNA? Yeah, absolutely. Think about this. You have double-stranded DNA of the herpes virus that ends up in the nucleus. Look at the bottom picture. Why DNA gets in the nucleus? what happens in the nucleus to human DNA? What is done to human DNA in the nucleus? Replication and transcription. So virus DNA uses all the same mechanisms, same enzymes, everything. Human enzymes for replication and transcription. Huh? Yep. So it's pretty toxic. Acyclovir is pretty toxic. It's a prescription drug here. Back home it is not. You can buy, well, not like the pills, but we have a cream over the counter that you can use in the cold sores. I never had a good placebo-controlled study on myself. I don't know if it's a cream that helps or actually acyclovir that helps with the cold sores. But for me it helps. Speaking of DNA, RNA, so you see DNA viruses, with some exceptions, they send their DNA into the nucleus because that's where the machinery is. Does that make sense? That's where the DNA replication machinery is. RNA viruses, with some exceptions, stay in a cytoplasm. Does it make sense? Because cell doesn't have enzymes to copy RNA, viruses provide for themselves. Okay? Papilloma and polyoma. Papilloma virus, that's the causative agent of warts. There's a little tiny warts. Infects epithelial cells. Are those epithelial cells? These ones. Yeah. Can virus infect them? Like these ones. Like these ones. The ones that you see on my hand, on your hand. Can virus infect them? You think so? These cells, are they alive? They're dead. Right? They're just filled with keratin. There's like bags of keratin here. There's nothing going on. There's no metabolism, no ribosomes. Virus cannot infect these epithelial cells. It has to go deep into the stratum basale, where live mitotically active keratinocytes dwell. So it infects them, then starts to replicate. But the thing is, the virus, the papilloma virus, which is double-stranded DNA virus, naked virus, has to replicate its DNA. Does that make sense so far? My train of thought for you. And as a double-stranded DNA virus, it uses the cellular enzymes to replicate its DNA. Okay? Essentially, the viral DNA is copied at the same time of the cell cycle as the cellular DNA. Can you tell me at which step of cell cycle the cellular DNA is copied? Remember, we never discussed it. It's basic biology. The S phase. Remember, every human cell, before it goes into mitosis, has to copy its DNA. Does that make sense? So the virus will use the same stage of the cycle to copy its DNA as well. And if virus wants, and this DNA copying in the cell is needed for mitosis. So virus pushes the cell into the division cycles because it can only replicate when the cell divides. Does that make sense? Do you understand what I'm trying to say here? Every time cell divides, it replicates its own DNA, and the same machinery replicates virus DNA. So virus pushes the cell to replicate, to reproduce. And you have an outgrowth that we call a wart. Just more cells. Okay? These viruses may become latent in different strains of papillomavirus are implicated in the cancers. So you can see that for some cancers, the number of HPV positive samples is pretty much all cases are HPV positive. Virus causes cervical cancer, HPV 16, HPV 18 mostly. Vaginal cancers, the anal cancers. Anal cancers is pretty much 100% linked to HPV, human papillomavirus. They implicated in head and neck cancers. So you can see, I don't remember, it was my typo, I just noticed it. You can see that many cancers are linked and essentially caused by human papillomavirus. Does that make sense? Now, this virus is transmitted by the contact route, and it gets into the little cut in the skin, or it gets into the damaged epithelium of the cervix, I want you to understand, these viruses do cause cancer, but cancer is not necessary for the virus survival and replication. It's a collateral damage that they cause. Does that make sense? How does it happen? We just discussed that virus stimulates cell division. With each division, cell acquires certain mutations. The more division cycles, the more mutations there are. The more mutations, the higher chances that some of those mutations will cause cancer, either activation of oncogene or inactivation of tumor suppressor factors. Right? We have a vaccine, Gardasil, that protects against papillomavirus infection. Of course, you want to see which effect does this vaccine have on the total level of cancer cases. And now we start to see the effect. It actually significantly decreases the cervical cancer in vaccinated women. It is given at the age of 12, 13, or earlier. Why? My boys are vaccinated. They got vaccinated at 11. Why at this age? Why not at like 40? Yep, by 40 you probably already have it. And it's not that effective. So you want to do it before the potential infection, and transmission of the virus can occur during the sexual contact. Okay, there's some people that claim that's my personal rant, little rant. Tell me if you disagree with me. It's perfectly fine, but I've heard the notion that if you give it to adolescents, to teenagers, vaccine, they would know that they are protected against HPV, and they will be more sexually promiscuous and active in searching for sex. I do not really know how a teenager can be more promiscuous or more searching for sex. Okay? It's that age. That's a lot of them, that's all they can think of. Okay? You cannot quench that thirst. Okay? And you cannot increase it because it's already at the top. Okay? Gardasil, the main side effect of this vaccine is the pain in the site of injection. Really. So, the multiple observations, it's very safe and effective vaccine. And it is good for boys too, because it prevents possible penile cancer, anal cancer, which is good. Okay. Polyomaviruses. There are two of them, very fascinating, that we're going to talk. BK and JC. Very creative names, I know. named, so BK and JC are initials of the patients from which those viruses were isolated. BK virus normally infects kidneys and remains latent in the kidneys for the lifetime. I would bet that 90% in that classroom are infected with BK virus. We may even shed it from time to time in the urine. And unless we become immunocompromised, we will never see any clinical syndrome associated with BK virus. However, in people who receive immunosuppressive treatment, BK virus can cause very severe damage to the kidneys, causing glomerulonephritis. That can lead to kidney failure and the need for transplant. JC virus is another great, interesting example. It is the infection, the disease associated with JC virus is called progressive multifocal leukoencephalopathy. Progressive means that it becomes worse. Multifocal, that there are multiple foci in the brain. Leukoencephalopathy, it's the disease mediated by leukocytes that occurs in the brain. Essentially, white blood cells migrate to the sites of infection and kill the brain tissue. And it happens in MS and AIDS patients. In AIDS patients, immunity is already down. Correct? What about MS patients? What is MS, multiple sclerosis? What is the mechanism of this disease? You are absolutely right. What breaks it down? Your own immune system, yes. It's type 3 and type 4 hypersensitivity. Okay? So, how do you treat autoimmune diseases? Generally, immunosuppressants. If you suppress immunity, JC virus has a field day, starts to replicate, and the mildly active white blood cells will still migrate and start destroy the virus and surrounding tissues. Did I tell you the story behind Natalizumab? That's the drug that is used for the MS treatment. It's an antibody. If you have a drug that ends with mab, like Natalizumab, it's antibody that targets one of the inflammatory cytokines. So it's immunosuppressant, but very, very targeted immunosuppressant. And it worked very well for MS patients, really well. It slowed the progression of the disease. And at some point, patients who were treated with that drug started to go down with PML, progressive multifocal leukoencephalopathy, that was caused essentially by JC virus. To give you an idea, that condition is untreatable and 100% lethal. And of course, the company that produced Natalizumab, it's one of the big pharma, I don't remember which one, they immediately called it off the market. But not just called it off the market, they addressed this issue with FDA. And not only FDA, they also brought the patient advocacy groups to the table. Because here's the issue. You have a drug that is extremely, well, the most effective drug to treat the debilitating disease like MS. And you have that side effect. It's not 100%, but the rates of side effect are pretty high. It's about 1%. 1 out of 100 patients develop this condition. So they brought it up in front of, before FDA and patient advocacy groups, and they had a discussion about this. And the decision was made to put it back on the market and put this in the side effects. Because those were MS patients that said, we want this drug. Without the drug, we're going to be progressively worse and die of the autoimmune disease. By taking this drug, yes, we can get this horrible, lethal, well, it's not like, not that your brain starts to drip out of your ears, but it's lethal disease that will kill you in a few months, but maybe not. So you are at risk, but not 100%. So it has been used since then. It's kind of, I like this story when the dialogue was built not only with the regulatory agency, but also with the patients. And there we go. That's the disease that everybody's familiar with, influenza. It's the negative strand, single strand RNA negative. The virus that sits in a capsid, and the virus as an envelope as well. Okay? One interesting feature of the RNA is that it is segmented. Think about this RNA as the deck of cards. It has 8 fragments. Okay? You need all 8 fragments to have a replication competent virus. So far, you keeping up? Because that's the great story. On the surface of the virus, there are 2 proteins, hemagglutinin, this bouquet-like looking thingies, the blue ones, and neuraminidase. Hemagglutinin got its name because if you add influenza virus to red blood cells, influenza will agglutinate red blood cells. Remember we did that lab about the blood typing? You're going to see the same picture. They will form a cloud. Okay? Its function of hemagglutinin is binding to the receptor. We good? Because virus has to bind to the receptor. Function of neuraminidase is to cleave, to cut neuraminic acid, a component of the virus receptor. That cut facilitates the infection of the virus. The penetration of the virus. Does that make sense? Let me show it. So if we have cell surface, we have a receptor, and we have the virus. That's going to be hemagglutinin that binds to the receptor, and the green is going to be neuraminidase. It cuts the receptor, and that allows virus to enter the cell. Does that make sense? Okay. Want to correct myself. Not only enter the cell, also neuraminidase is necessary for the virus to leave the cell. But let's put it on the back burner. Have you heard, how do we, when you hear about the influenza epidemic, how do they call the strains? H1N1, H5N1, H3N2, H7N7. It refers to different types of hemagglutinin and neuraminidase. There are 16 types of hemagglutinin, 9 types of neuraminidase. The combination gives you that serial number. And the combination defines which receptor the virus can bind, and essentially defines the host range. For instance, H7N7 infects seals, but not. Can infect humans, but not transmissible. H1N1, H2N2, H3N2 can be transmitted between humans. H5N1 cannot be. H13N9 infects whales, not humans. Do you understand the idea of that combination? It's like lock and key. I hate this analogy, but I have nothing else. Okay. So when you hear things like H1N1 influenza, you know that it's specific type of hemagglutinin, specific type of neuraminidase. The problem is that different hemagglutinins, different neuraminidase, they all induce immune response but those immune responses are not cross-reactive. Do you understand the idea of cross-reactivity? No? Let's talk about it. Do you know what is the process of the vaccine, influenza vaccine development? People gather, first step is gorgeous. I would love to participate. They all gather in Lausanne, Switzerland. I would go there like tomorrow. But instead of enjoying Switzerland, they sit in the room in WHO or Geneva, whatever, Switzerland, that's important. They sit in the room of WHO headquarters and look through the reports, epidemiological reports, trying to figure out which strain is going to be most common in the upcoming year. It's educated guess. So it's not 100% guaranteed shot, okay? They have a consensus, and then they publish the report. Pharmaceutical companies pick up that report and start to make a vaccine, relevant vaccine. Say, last few years it was H3N2. Say next year they say it's not going to be H3N2, it's going to be H1N1. So companies will start making vaccine against H1N1. If the guess was correct, good for us. If the guess was not correct, it's like you never took vaccine. Does that make sense? So universal vaccine is essentially an issue. How can we make universal flu vaccine? We actually can. There's a work. There's like one in the trials now. We may be that close. Turns out there are some parts of hemagglutinin that different viral strains share. They're common. So now they attempt to make a vaccine against this part. Actually, it's a stem part of hemagglutinin right here. So they want to target not the ever-changing head, but the conservative stem. Right? It's pretty cool. I mean, they work on it. I don't know if it's going to be successful or not, but there's a work done. So influenza is the zoonotic infection. As you can see, that's kind of illustrative. The regular transmission route for humans, the disease goes from waterfowl into the pigs, and then from pigs it gets into the humans. Pigs is a necessary step. Now on this flow chart, you can see the dotted arrow that goes from waterfowls to humans. And we will touch on that, okay? We will touch on that. But there are some interesting mechanisms associated with that step. So, in birds, the disease is gastrointestinal. In pigs, it becomes respiratory, and then pigs give this disease to humans. And of course, humans can maintain the virus in their own population. So we can just transmit it to each other, right? Interestingly enough, the best animal model for influenza, ferrets. They can transmit the infection by coughing at each other. Mice don't cough. Seriously. And ferrets have similar anatomical makeup of the upper respiratory tract. And they have the same receptors. So let's talk about receptors. Humans have a receptor for influenza, which is called alpha-2,6-sialic acid. Birds in the gastrointestinal tract have alpha-2,3-sialic acids. Those receptors, although similar, are not identical. So hypothetical flu coming out of the rear end of the bird cannot cause, now listen carefully, upper respiratory tract disease in humans because receptors don't match. Does that make sense? So it has to go through pigs, acquire some mutations to be able to infect humans, interact with alpha-2-6-sialic acid. Sorry about that. So far, does that make sense? Sorry, the bird flu. We're getting to the interesting part. Ever heard about it? I could probably just Google bird flu. There would be like 2 feet tall headlines in the newspapers. We're all gonna die. It's a deadly flu that's gonna kill all of us. Humanity is under the threat. There are cases, regular cases of bird flu in China. Bird flu in China is acquired from which birds? Not the waterfowl, unless you're like chasing the duck and breathe, well, from the anus. Yes. Huh? Chicken. Poultry, well, mostly chicken. Did you see ever the photographs of the chicken farms? Are there many birds? Jesus H. Christ, there are so many birds. Like, I don't know, thousands of birds. And what birds usually do, like on a regular basis? Crapping, yes, they crapping notoriously everywhere. And when they're crapping, and such massive numbers of birds crapping, the poop gets aerosolized. Now imagine you are a Chinese worker at the poultry farm. It sounds awful, I know. Very politically incorrect statement, but it is. Let's admit it. And you, like, I don't know, scraping the floors. It's a hard labor. So from time to time, you're going to do this. You're tired. So you're going to inhale all of that bird feces. Where? Deep into your lungs. Deep in the trachea. Where you have the receptor. The same receptor as birds have in the digestive tract. Alpha-2,3-sialic acid. So if you would look at the clinical reports of bird flu, those cases are severe, very severe cases. Because people get the infection not in the upper respiratory tract. They don't get pharyngitis. They get it right into the trachea, right into the lungs. They end up with tracheitis or viral pneumonia. It's really bad. A lot of people die. Does that make sense? Can these people transmit the disease by coughing? That bird flu. When somebody coughs and you just speak to a person, which part of the respiratory tract gets infected? Upper. So although they have infection, even if they cough, the virus cannot infect your upper respiratory tract because receptors don't match. Does that make sense? Unless, of course, you know, like you take infected person coughs directly in the mouth of uninfected person, and uninfected person takes a deep breath. I cannot possibly think of those circumstances, right? So, bird flu is not communicable disease. At least we have no reports of bird flu transmission between the humans. Does that make sense? Just don't be that scared. And another thing about the deadliness of the disease. Remember we discussed prevalence, incidence, mortality, morbidity. We don't really know how many people are infected asymptomatically. Seriously, we don't. So, we don't know, it's still a question. So don't fall, into that fear-mongering. We're all going to die. Symptoms, I'm actually going to kind of skip. Everybody knows that, really. One thing, there is no stomach flu. Period. Influenza does not cause digestive symptoms. If you have digestive symptoms during influenza, it's something else, but not influenza. There is no stomach flu. There are viruses that cause it, but not the flu. Treatment. Do we have any effective treatment against influenza? We have none. We used to have amantadine, which inhibited hemagglutinin, I think. Yeah, we got resistance. Virtually all strains of flu are resistant to amantadine. Then, you'll remember Tamiflu and Relenza. Were they effective? That's the right facial expression that you should, yeah. There's a, like a body of people called Cochrane collaboration. People review the clinical data and issue like a big review on the efficiency of certain treatments. So Cochrane review of Tamiflu Relenza efficacy showed that it does reduce the longevity of symptoms by 12 hours. The general recommendation based on the clinical studies, there's no point in using these drugs. Another thing, when they came out, they became hugely popular, and in Japan, these pills were prescribed like, I don't know, lollipops. The amount of Tamiflu that Japanese folks were taking was so huge that there were studies that detected Tamiflu in the sewage. So people peed it in gigantic amounts. Tamiflu was in the sewage. It was very well detectable. Well, guess what virus developed eventually? Resistance. Practically all strains are resistant to Tamiflu. However, if you will talk to a physician and ask, would you use Tamiflu? Physician would probably tell you depending on the patient. In us, like if you're a healthy adult, influenza, is it going to kill you? Probably not. The mortality, about 0.4, 0.1%. Okay. Well, not mortality, case fatality ratio. However, if you are an ICU patient with, what should I call it, ischemic heart disease, or you have like the atrial fibrillation, so you have a propensity to develop stroke, then probably the doctor will prescribe Tamiflu just to be on the safe side. Maybe it will help you. Does that make sense? Because there is a study, so I give you the influenza mortality. So it's a period for 30 years. They give you a range. 1 year it's 3,000, another year it's 49,000. Now here's the problem. The patient with the flu, the patient has nothing but the flu dies. The patient died of the flu, right? The patient with the flu, patient develops secondary bacterial pneumonia like strep pneumonia and dies of bacterial pneumonia. What did he or she died from? Technically, bacterial infection. But probably without the primary influenza infection, there would be no death. Does that make sense? Some people estimate that every year, about 200,000 people in the US die of the influenza and associated conditions and complications. So, the pressing question, should you get vaccinated? Who got vaccinated in, well, flu season is like way behind us. I got vaccinated. Good job. This is the altruistic vaccine, which means if you're healthy and you don't get vaccinated, you may get an infection. Yeah, but you're going to be fine. I mean, you're going to get sick, but you're going to be fine. But if you get vaccinated, you protect people who are weak, kids, okay, people with cancer, immunosuppressive treatment, surgical treatments, elderly. And the more people we get vaccinated, the better we can break the cycle of transmission. Does it make sense? So it's in essence it's not necessarily you that benefits. It's other people that benefit from this vaccination. I strongly encourage people to vaccinate again, take the vaccine again against flu. Here on campus, I think it's like $20. Your physician will probably do it for free. There are two forms of vaccine, injectable and spray, nasal spray. I don't remember the names. The spray lost the popularity because studies showed it wasn't really effective. Why? Dose problem, you know, because it depends on how well you inhale. Although the idea was brilliant, really. It was an attenuated influenza virus, so it was weak virus. You delivered it where it's supposed to be, in the respiratory epithelium. So you do it as natural as possible, but the dosage problem, okay? Injectable worked better. You know what? Let's wrap up because we're going to talk about Ebola and other stuff later. I bet you're going to love it.